I'm Dr. Lindsey Rolston, and today I'd like to simply go through my evaluation of a patient that has an arthritic knee and what we think about in terms of symptomatology and how it correlates with the x-rays that we have. I think we first need to understand, and patients need to understand, that the pain that originates from an arthritic knee is dependent on the location of the knee where the pain is at. So this is what our normal knee is. And this blue surface is about 5 millimeters thick. All of our joints have this surface. It is at our shoulder, elbow, wrist, hip, knee, and ankle. And this covering has no nerve tissue. So our normal joint, which is what this is, has normal and no pain. This surface is given to us once in our life. The surface, again, has no nerve tissue, and therefore there is no pain. When we lose this covering, as in what we see here, this surface is now down through bone. Bone has nerves, whereas the normal covering has no nerves. This is not painful. This is quite painful. And unfortunately, there's no one in this planet that can grow this blue stuff back on the end of the bone. So bone on bone is nerve on nerve, and that is the essence of what arthritis is. So if you look in the dictionary, bone on bone is nerve on nerve, and that is what arthritis is. So as we look at our x-rays then, a more normal knee, this knee here on my left side, the reason there's this black covering is because we have the normal amount of covering on the end of the bone. So this is relatively normal. That's what we want. If we look over here to this side, this is normal on the outside of the knee, but unfortunately there is bone on the inside. So this is what arthritis looks like on an x-ray. And it's not certainly mandatory that we obtain an MRI or further diagnostic testing to tell whether there is an arthritic knee or whether there isn't. So once we know from an x-ray standpoint where the arthritic area is, we want to be able to see whether that correlates with the same portion of the knee that the patient is actually complaining of. So in this instance, this is the inside part of the knee, and if they have pain on the inside part, then the diagnosis is essentially confirmed. So bone on bone is nerve on nerve, and that is what arthritis is. And unfortunately, like we said, growing this covering back is not possible. And there's nothing on the horizon that appears like we're going to be able to grow surface back anytime in the near future. So once we know we have the diagnosis, the next question is, how can we treat this? So from a conservative standpoint, the options include soft-soled shoes to cushion as we walk, Motrin, Advil, Aleve, anti-inflammatory medicines, Tylenol, prescription anti-inflammatory medicines are possible, but probably don't work a whole lot better than high-dose over-the-counter anti-inflammatory medicines. So medicines, injections, cortisone injections can be tried. They have no ability to regrow the cartilage. They can sometimes take away symptoms in the short run and make people better for a period of time. And as long as the injections are working, they can be done indefinitely. And we have a chance to do approximately 3 to 4 injections per year, and we can't do them necessarily any more frequently than every 3 or 4 months. If the injections fail, the medicines fail, the soft-soled shoes fail, perhaps some exercises to keep our muscles strong, this is when we then consider surgical options. And unfortunately, when we get a bone-on-bone type scenario like this is severe, end-stage osteoarthritis is what we're looking at in this picture. And this is extremely common, and in those people that have failed conservative care, knee replacement surgery is what we then have to offer. There's approximately 700,000 knee replacements done annually, and that number is expected to double by 2035. So it's a very, very common operation. It's one that we do here at Henry County Hospital several hundred times a year. We have things to think about when it comes to the surgery, and my description and my discussion with patients with regards to the surgery goes something like this. The surgery is a 45-minute operation. It is an operation where we basically take off the surfaces and put new caps in place. This is what a total knee replacement looks like. This is a model, and I'm going to take off the implants. And this really shows just the amount of bone that we're taking when it comes to replacement surgery. And these are what the implants look like. They can either be cemented or press fit without cement. And there's advantages and disadvantages of each. So this is what the replacement looks like. The implants are placed at the time of the operation. It's about, again, a 4 or 5 inch incision on the front of the knee. And the patients are typically able to be weight-bearing, full weight-bearing with a walker and with a therapist on the first post-operative day. So the surgery, patients typically are able to, again, weight-bear fully with the walker for the first week or maybe 2. Patients are able to switch from a walker to a cane in the opposite hand, typically within 1 to 2 weeks, and they may need the cane for as long as 6 weeks. Patients are able to typically weight bear, no cane, no crutch, no limp by 6 to 8 weeks. Now, by no means does this mean that patients are completely healed and cured at that stage. It is a situation where most people will have some swelling, achiness, stiffness in their knee for the first 6 weeks, and even sometimes beyond. But the function, meaning what patients are able to do, is quite good at the 6 to 8 week mark. They're usually able to drive, walk, no assistive devices. The typical follow-up period of time would be 2 weeks we would take staples out, 6 weeks we would take x-rays again, and at that point the follow-up would not necessarily need to be until 1 year or maybe 2 for a follow-up. Patients typically have a very, very good result. The importance of the operation, or the purpose of the operation, is to alleviate pain, but unfortunately it's very important for everyone to understand there are some limitations afterwards. Running is a difficult thing for people to do, stopping and starting specifically. So running is okay, but stopping and starting is quite difficult. Kneeling down on the knee is tender for the first year. It's okay to kneel, it won't hurt the implants, but it's tender for the first year. And so we tell people to use a stool or use a pad if they need to kneel. There is a benefit in people continuing therapy beyond the first 6 weeks, and typically this is therapy that they would be doing on their own. The longevity of knee replacement surgery was once felt to be less than 10 years, and then we felt that we had implants and technology that allowed 10 to 15 years. Now we think there is a chance that our patients could have literally a lifelong benefit from knee replacement surgery. That may not be the case for everyone, but we think that the technology is going to allow for this. We need to keep in mind that we've only been doing knee replacement surgery worldwide for 50 years. So for me to predict a 50-year response to a knee replacement is certainly a projection, but we think that what we've seen at 10, 15 years with implants that we're doing these days, that we have a chance to perhaps create a forever knee. I certainly hope this has been helpful, and if there's any questions, you have my cell phone to discuss this further preoperatively or after surgery if you elect to have the operation.